Hello, everybody, and welcome to the International Thyroid Awareness Week webinar for 2025. We are also celebrating the 30 years of our existence of Thyroid Federation International, which was formed in 1995 during the ITC meeting in Toronto. Um, we also created International Thyroid Awareness Day, which is World Thyroid Day for 25th May, which was in 2009 and now celebrated and adopted by all others associations connected with the thyroid area. Apart from that, we have International Thyroid Awareness Week. This is the 17th year that we are doing International Thyroid Awareness Week, which always begins from May 25th to May 31st. And during this time, we have two lectures. Today, in this series of International Thyroid Awareness Week, we have a first lecture, Thyroid and AI, which is artificial intelligence. And the next lecture will be on 31st May, which is going to be on thyroid eye disease. Before I go further, I wanted to thank all our sponsors, without which it's not possible to be able to bring education and awareness and webinars like this to you. So thank you again for all our sponsors, which are shown here in the slide. I wanted to introduce Dr. Brendan C. Stack, Jr., MD, FACS, FACE, who attended Brigham Young University. Dr. Brendan is the former professor and inaugural chairman of otolaryngology, head and neck surgery at the Southern Illinois University of Medicine in Springfield, Illinois, and has been a faculty member at the University of Arkansas for Medical Sciences, Pennsylvania State University, and St. Louis University. Dr. Stack has authored over 300 peer-reviewed papers, chapters, and internet articles, apart from some books that Dr. Stack has written. He has been an editor of Medical and Surgical Treatment of Parathyroid Disease and Evidence-Based Approach. Dr. Stack has appeared or has been cited by local and national media numerous times. He served on the editorial boards of Head and Neck Otolaryngology, Head and Neck Surgery, Video Endocrinology, and the ENT Journal. We are very fortunate and lucky to have Dr. Brendan C. Stack present us with thyroid disease and AI. So over to you, Dr. Brendan, and thank you so much for taking the time to help us out with this presentation today. Without further ado, here's Dr. Brendan Stack.
Hello, and good day to all of our audience throughout the world. My name is Brendan Stack, and I've been asked to talk about artificial intelligence and thyroid disease. I'd like to thank the organizers and the leaders of TFI for this opportunity. These are my relevant conflicts of interest. They're basically all books that are that I've edited and are in current circulation. Before we get started, I want to let everybody know that I am a member of the American Head and Neck Society. This is an organization of head and neck surgeons, of which a significant group are dedicated to endocrine surgery. So we are going to talk about artificial intelligence. We're going to talk about what it is, why use it, how it has been used in the past, types of data that are used for it. I'm going to talk a little bit about previous work that I've done in the review machine learning or artificial intelligence and thyroid disease. So artificial intelligence is oftentimes called machine learning. And really what these are is a suite of computational tools that are powered by high-powered computers. It allows for identification or analysis of a condition, which could be a diagnosis, an exam finding, etc., that may be contained, and I emphasize hidden because when you have billions of medical records and maybe hundreds of findings, it can be relatively hidden in a vast data repository. This technology allows for a rapid and automated processing of large volumes of data to discover relationships which might escape clinical notice in common clinical practice. It leverages large data sets and clinical experiences to modify processes or procedures in the clinical environment. And it can actually be a plug-in to existing electronic medical records and can automate some of the care that's provided on the front lines by providers with electronic medical records. So this is a figure that I designed a while back to emphasize the relationship between providers and artificial intelligence and the data that we have. If we start at the bullseye with the physician and we extend out like a pebble that drops in a pond and the ripples go out on the surface order after a education, we have the clinical practice. We have maintenance of certification, which is required by governmental authorities. And we have quality assurance and continuing improvement processes in our institutions. We go out another rung on the target, and we have peers that we consult with. We have access to systematic reviews. We have practice guidelines, which are published by our various specialty societies and organizations. We even have organizations such as Cochrane, which provides high rigor, high evidence reviews. And then beyond all of that, and the latest development that has impacted our ability to care for patients would be artificial intelligence or machine learning. So one way we can frame this is we have our current knowledge. We can describe that we know what we know in the moment. We've been taught this, we've experienced it in our own lives. But what artificial intelligence and machine learning has the power to do is it can help us identify what we don't know. Oftentimes we already know this, but even more importantly, it will help identify what we don't know that we don't know. So the way that this quote goes together is we know what we know, and we know what we don't know, but we don't know what we don't know. And really that last frontier of improvement, of obtaining knowledge, of moving medical care forward for the benefit of our patients. So what are some practical applications of these tools? You know, a lot of times we're given a tool, let's say a hammer, and all of a sudden we use this tool, the hammer, in all sorts of situations. The quote is, if you have a hammer, the whole world looks like a nail. Well, we don't want to push the technology to inappropriate uses by using it broadly and in an unspecific manner. But there are many practical applications for this technology. We can study large populations, such as the residents of India and China and throughout the world. We can identify obscure conditions. They're often called orphan diseases, which in the United States are defined as fewer than 200,000 cases. But this is like looking for a needle in the haystack. We can provide care for underserved groups, and these could be groups that were underserved economically, culturally, racially, geographically. Really, there's no limit to how we can provide care to underserved groups. And we have the potential to cross historical boundaries and barriers of care, service, and technology. And this can be boundaries created because of a lack of wealth and a lack of access to technology, or they can be boundaries based on prejudice and bias. And artificial intelligence and machine learning has the potential to cross all of these. machine learning, there's a little jargon that I think is worth educating you about to improve your sophisticated use. There's supervised artificial intelligence, and this is learning that is performed by using a training set composed of randomly selected observations with outcome variables included to predetermine a preferred pattern or feature of values. I am going to give an example of using artificial intelligence in this supervised model later in this talk. There's unsupervised, and this is learning aims to sort data by similar characteristics or features without the addition of imposed outcome variables. Now, this is what's considered by many critics of artificial intelligence and machine learning to be the black box nature, that there's a lack of transparency. And basically, unsupervised machine learning is where the computer is teaching itself without any outside interference. And this can be very helpful and certainly can automate the process, but this is something that deserves scrutiny, especially when we're introducing new artificial intelligence tools. Finally, there's the term ensemble learning, and this is where previously defined algorithms are put together in order to improve the performance of the artificial intelligence or machine learning. So it's sort of a step into artificial intelligence and machine learning in order to perfect bias in artificial intelligence. Artificial intelligence is not immune from bias. If you have historically biased data and you're using that for the construction of your artificial intelligence, that bias is going to carry through. Now, we can correct for bias, we can eliminate bias, and this will ultimately improve the machine learning and the artificial intelligence. But this has to be recognized and has to be acknowledged during the process. Let me give you some examples from my country. In the United States, being of African background, or as we would say, Black, is associated with poor morbidity, mortality, and survival. Now, this poor outcome is not as a result of being Black because of their physiology or genetics. It has to do with social constructs. So if we were to use historical data treating Black patients in the United States, some of those biases historically might be reflected if we were to move it forward into modern machine learning and artificial intelligence. So this is something that needs to be recognized and addressed with machine learning. So one thing to sort of summarize this slide is the expression GIGO. And this is really important, and I think really emphasizes the importance of our data that we use in machine learning. And that stands for garbage in, garbage out. So if you put garbage data into a system, no matter how garbage type of results compromises a result. Now, how have we used artificial intelligence in machine learning? It's to help us process data in various different domains. And these are a few examples that have been used across all of medicine historically. This has been used to help in the diagnosis of autism from using functional MRI scans. It's been used to predict patients that will succumb to chemical dependency. It's been used to identify biomarkers and validate them. It's been used to look at microscope slides containing cellular aspirates to do cytologic screening. It's been used to take the data from monitoring devices during general anesthesia or in an intensive care unit and come up with warnings and conclusions and whatnot. It's been used in sensor development and refinement. It's been used in the analysis of DNA data and some of the subsequent products of DNA, specifically protein, to help analyze those products and make designs to propose changes to DNA. It's been used in the analysis of medical and scientific literature. And up to this point, it's been managed by the Food and Drug Administration in the United States like a medical device, like let's say a pulse oximeter or something else. And they have received applications to approve setting in the United States, but there's not been a blanket approval. It's been done on a case-by-case or situation-by-situation basis. So just a little more specifically about the types of data, one thing you will notice that really there are no limits on what data can be analyzed or processed using artificial intelligence. You can take pictorial data such as medical images, and I've listed several there. You can take diagnostic data such as pathology, whether it comes from cytology or histology, it doesn't matter. Both have been incorporated into artificial intelligence. And you can even take text. Now, of course, text would be printed information, oftentimes contained in the electronic medical record. But you can even take voice, which has been converted to text through, and then this text can be made into processable data through natural language processing. And there's a whole area of research related to taking human language and turning it into data that can be processed. It's a very robust field at this time. So what do we do with our big data once we've overcome some of the obstacles to technology to get access to big data? Well, we need to process that data so that it's interpretable. And one of the first things that we do when we're going to embark upon a new disease that we want to look at is we need to come up with a data phenotype. Now, that word is significant. When we use the words genotype and phenotype in medicine, genotype means what's your DNA say, and phenotype is how do you look, how do you appear? Well, in machine learning, we use data to then make an assessment of a patient, their phenotype. And so what a data phenotype is, it's by identifying certain elements of a patient's characteristics. It could be anything from height, weight, biometrics, anything. And we take that, and upon studying it and validating it, that it has a connection to the disease that we're interested in studying, we can construct what's called a data phenotype. So part of the steps that are required, it's not enough just to have the data dropped in our lap. We need to extract the data. Sometimes this requires scanning from archival information that is not even digitized, so that would be analog. Ultimately, we're putting all this data into ones and zeros. We're making it digital so that we can process it. We need to get access to certain databases, some of which are proprietary and don't have open access, and that can be an obstacle as well. We need to do a pilot analysis. Basically, this is hypothesis testing, hypothesis refinement. And that refinement can happen over many iterative steps over an extensive period of time. And then once we have refined our model, then we need to validate it on open, unprocessed, not previously studied data. And that's what summarize the process that we need to go through when using artificial intelligence and machine learning. Is we need to we start with developing a data phenotype. We use this to discover relationships of significance that we did not previously appreciate. We use it to improve the efficiency of making a diagnosis or performing a treatment. Because we use this technology and we're using ultimately such robust data and have quality instilled in this process, it will naturally over time become very cost effective and economical. We formulate best practices as a result of our discoveries. We hope and strive to eliminate any bias that might be incorporated in the data that we use or the processes that we use with said data. And this gives us the power to extend the knowledge and the improvements of modern technology throughout all of humanity, including especially underserved or under-resourced or remote locations. Ultimately, we have the power, and I'm switching gears from processing and diagnosis to now back to medicine. This tool will give us the opportunity to discover root causes of diseases, many of which have yet to be appreciated in our modern practice. So what I'd like to do is briefly transition to a disease state that is close in anatomic proximity to the thyroid, but a little different than thyroid disease, as an example of going through this process. What is hyperparathyroidism? Well, it starts with hypercalcemia. That's a person that has elevated calcium levels in their body. And the most common reason for a person to have elevated calcium is that they're suffering from hyperparathyroidism. It can be caused from certain diseases such as metastatic cancer, but this is less common. Walking around with elevated calcium may seem somewhat innocuous, but in fact, it can cause renal damage if left untreated. And recent studies have shown that up to 75% of patients in large electronic medical records have hypercalcemia that never undergoes further evaluation and treatment. In addition to hypercalcemia, hyperparathyroidism has other borderline conditions which may represent a pre-disease state, and these need to be recognized as well. So as I said, the majority of hypercalcemia goes unrecognized, and the delays have a cost. The incidence of primary hyperparathyroidism seems to be on the increase across genders, races, and geographic borders. And there seems to be a lack of appreciation of the clinical significance of this disease by the majority of frontline healthcare providers and workers and what have you. So we have multiple things going on here. We have a disease which is increasing. And we have an education opportunity in order to address one or both of those issues. The sine qua non for making this diagnosis of hyperparathyroidism is to have hypercalcemia, elevated calcium, and elevated PTH hormone at the same time. Well, testing for PTH hormone can be limited. So the goal of our research was to be able to use a data phenotype that did not include calcium or PTH values to make the diagnosis of primary hyperparathyroidism, so that we could make this diagnosis throughout the globe without having those particular biomarkers, and then allow these patients to be further evaluated or referred on to centers where that could be achieved. Here's just a review of how over the recent years we've had multiple reports, including from our group, of underreported or non-reported hypercalcemia. So what made me in particular interested in this? Well, as a practitioner of endocrine surgery and specifically taking care of hyperparathyroidism in the United States, I've over the course of my career noticed that there was a change in this disease. And this has been reflected on a few large-scale studies. This is data from the Mayo Clinic that shows a gradual increase of the slope over time. And here's the same data presented a little differently. And this has happened in both genders, more so in women than men, but it has happened to both. Observation. So this led to the questioning and the formation of some hypotheses. Why is primary hyperparathyroidism becoming more prevalent? Is the nature of primary hyperparathyroidism changing? And we see evidence of that because we see more and more patients presenting with borderline elevated calcium and elevated parathyroid hormone. We also, in treating this disease, have seen the classic disease of one gland being enlarged now transforming into more of a multi-gland disease. So what I just spoke about was this project that illustrates the points of machine learning as we've applied them to clinical practice. Here you can see how we took a large amount of data, in this case almost 2,000 observations in a selected population, and then we excluded confounding factors such as cancer, renal dysfunction, and we resulted with a very small group of about 2. This is a very busy slide, but on the left, what is demonstrated was all the things we were looking at with our machine learning at the beginning. And to the right is where we were able to refine through using machine learning down to a much more manageable set of data. And then you can see on the right, there was a round 1 and a round 2, which further illustrates the iterative process of designing tools with data in the process of machine learning or artificial intelligence. Bottom line is, through our process, we were able to, with an 86% accuracy, going from 0 accuracy before this test existed to now 86%, which is quite a advancement with one foray into artificial intelligence. We are able to make the diagnosis of primary hyperparathyroidism without knowing the patient's calcium level or PTH level in advance. Now, this is what's called an AUC, an area under the curve, and this is a common tool that we use to study the effectiveness and the accuracy of our tools. And so I'm going to compare our results, which are on the left, to another study that was done in the same arena with just using PTH. And you can see our data is superior. And what makes it superior, for those of you who are not familiar with looking at AUC curves, is the more to the left that the curve goes and the squarer it does, the more area there is under the curve, the more accurate the curve is. So you can just see diagrammatically that our curve to the left is better than the data presented on the right. So back to thyroids, as we summarize, how can artificial intelligence, how can going through a process that I described to you that I did with hypercalcemia be employed with thyroids? Well, it can help with the diagnosis. And this is real significant because commonly, clinically, we have people that don't have enough thyroid function or have too much thyroid function. And both of those, more likely than not, are caused by an autoimmune condition. So artificial intelligence can help us manage patients that are hypo and hyperthyroid. Very common in thyroid is nodules. And the concern is always from the patient and provider perspective is that nodule benign or malignant? And artificial intelligence can help us figure that out less invasively than we have done that historically. And within the domain of thyroid malignancies, it can help us understand the aggressivity, the likelihood that it would recur, and it will allow us to appreciate the differences that we see among thyroid malignancies among the papillary and the follicular, which is a group, are called differentiated thyroid cancers and are by far the most common. Surgery, as far as complications related to the voice, swallowing, hoarseness, or even the complication of hypoparathyroidism, which can result from complete or multiple thyroid surgeries being done. Ultimately, all of these technology is going to lead us to new technologies, not only new technologies in the domain of artificial intelligence and machine learning, but new technologies that will be used in the medical practice, such as tools to treat thyroid nodules, or medicines, or supplements, or other remedies. Artificial intelligence and machine learning for thyroid disease is no longer theoretical or a subject of science fiction. It's ongoing presently. This will proliferate in its scope and its impact upon patients that suffer from thyroid disease. It offers the promise of a data-driven approach to medical care that can be personalized to the patient level and will allow for continuous quality improvement over time. I thank you for your attention to my talk, and I wish you success and health and happiness in your lives. Thank you.
Thank you, Dr. Brendan, for that was an excellent, insightful presentation. And I'm sure all our audience, which is from all over the world, has enjoyed this. And thank you for all of you from India, from Southeast Asia region, from the Arab world, from Africa, from Europe, and the Americas, and the Pacific region to join this presentation today. And I hope it has been beneficial because this topic of AI, artificial intelligence, and how it can benefit us is a very contemporary one today. Again, I wanted to take a few seconds to also thank our sponsors, without which we would not be able to bring such excellent webinars and presentations to you. And I wanted to thank all the TFI board and all the TFI members for being a big part of this, without which we would not be where we are today in our 30 years. And our next webinar is going to be on 31st May. You will get information through your various societies and email that we have, and you will get the information when it is. You make sure to register in time and also to log in after registration on 31st of May, which is part of International Thyroid Awareness Week. Thank you very much, and thank you for joining, and bye for now.